All right, recording should be good. Did everyone see the link to sign in? For those of you that just got on, I'm going to repost it. Make sure you sign in. All right. If everyone's good, I'm going to go ahead and get started. Can you guys hear me all right? Let me know. All right, cool. Okay, so I was telling people earlier, I thought it made the most sense for me to go ahead and review all of the reproductive anatomy, just because I missed last week, and I think this is more difficult to get than leg. So I wanted to go back over those first two lectures and do all of repro and hopefully help you guys get this down. And then next week I'm going to do all of leg. So I didn't want to like split my time between repro and leg. I just felt like this made the most sense to do it this way. So I am going to cover leg next week. All right. And if you were here for my last session, these first two lectures, some of this is the same stuff, but I've added a lot of slides too. Okay, so let's get started. If you have any questions, feel free to type in the chat box. Try to keep it on that. And then also, you can unmute yourself and talk too. I'm totally fine with that. Okay, so pelvic cavity is composed of two different regions, the false pelvis and the true pelvis. So the false pelvis is everything related to the ilia and the lower lumbar vertebrae, and your sigmoid, colon, and cecum, so the lower intestines. And then the true pelvis is related to the pubis, the ischium, and the sacrum. And you're bound by the pelvic inlet and the pelvic outlet. And then, of course, your urinary and reproductive organs. And then the perineum, so everything in what she referred to as the outside world, is down here. And that's going to anchor the roots of the external genitalia. And then you have your openings for the GI and UG tracts. And then it provides support to the pelvic viscera. Pelvic osteology, your pelvis is composed of three different parts. So you have a right and left os coxa. So coxa would be singular, and coxae is referring to two, the sacrum and the coccyx. And then down here, you really need to know the three parts. So you have an ilium, an ischium, and a pubis. So the pubis is facing anteriorly, and then the ischium is facing posteriorly. And a few important landmarks up here, the ASIS and then the PSIS. So I'm betting you guys have probably palpated these in OPP by now. Is that right? And what would you call this down here? This isn't as important, but just for completeness sake. Yeah. So the posterior inferior iliac spine, and then the anterior inferior iliac spine. So ASIS and AIIS and PIIS. Okay. So this was a test question last year. Make sure you know the difference between the female and male pelvis. So females are going to have a more broad circular pelvis, so they can fit the head of the baby down there, and a wider pubic angle. And then males have more of a narrow heart-shaped pelvis and a smaller pubic angle. Definitely do not worry about the degrees. That is not important. At least at this point. I mean, if you were an OB, maybe it is. All right, so I stuck this slide in here So I know that I've heard that during your lab practicals, and it was the same for us, that they can hang like an X-ray or CT or some sort of imaging up on the screen. So this is one example of something that they might hang, and they can label one of the parts of the pelvis. So make sure you're familiar with looking at the pelvis on X-ray. Can everyone make sure that their mic is muted? All right. So I think it's best to learn the bony landmarks in reference to like what attaches there, because I think that's probably how you've seen it tested on the practical. At least that's how it was for us. So I know the anatomy faculty is like, oh, sit down with a bone box and just memorize every point. I kind of think that it'll stick better if you memorize it based on what attaches there. Okay, so first off, what are the attachments of the inguinal ligament? That's going to give you two important landmarks right there. Yes, the ASIS and the pubic tubercle. And then what structure travels, or what structures travel through the obturator foramen right here? Correct, obturator nerve and artery. And then what are the attachments of the sacrospinous ligament? So sacrospinous ligament. Yes, the sacrum and the ischial spine. So ischial spine is right here. And then what are the attachments of the sacrotuberous ligament? The sacrum and the ischial tuberosity, correct. So those ligaments, the sacrotuberous and the sacrospinous, they will definitely tag one, if not both, on your practical. It travels with the artery and nerve. All right. So two very important foramina here, formed by these sacrospinous and sacrotuberous ligaments. So the first one is the greater sciatic foramen, so this area right up here. And then you also have the lesser sciatic foramen. So the greater sciatic foramen, traveling through it is the piriformis muscle. So that muscle is going to originate from the sacrum and then travel anteriorly to attach on the greater trochanter of the femur. And then your obturator internus, which is lying on that obturator membrane, it's going to travel through the lesser sciatic foramen and also attach to the greater trochanter of the femur. So, thinking ahead, something they could do on the practical would be, lay out the femur, and they could tag the greater trochanter and ask you what attaches here. So when you study the osteology, that's how I would go about studying it. Think about your attachments. Okay. Okay, so this slide is just showing you what travels through each of these foramina. So the important ones that I want to point out is the fact that the superior gluteal neurovascular bundle is going to travel through the greater sciatic foramen above the piriformis. So the piriformis is going to divide your greater sciatic foramen into kind of like two areas. So we have an area that's considered above the piriformis in the greater sciatic foramen, and then an area considered below the piriformis, so above and below. And both of these are still within the greater sciatic foramen, but just kind of divided up. Passing below the piriformis, you have the inferior gluteal nerve, artery, and vein. And then I would say the second most important point of this slide is that the pudendal nerve and internal pudendal artery are going to travel through both the greater and the lesser sciatic foramen. Okay. No, we just refer to them as so within the greater sciatic foramen, but either above the piriformis or below the piriformis. All right, so most important on this slide, and I listened to the male and female lecture, and she explicitly said that you will have a question on this, so make sure you know the recto-uterine space. So recto-uterine, recto is referring to the rectum, and then uterine referring to the uterus. So between the uterus and the rectum is the recto-uterine space. And why is this clinically significant? Right, fluid can collect there. So this is the one that they're going to ask you about. And I went through Gray's. I have a bunch of questions at the end from Gray's. And this is the space that Gray's focuses on too. So definitely know this. All right, so I'm going to go on to the perineum. So your perineum is divided into urogenital and anal triangles. So here are the boundaries of your urogenital triangle. And then back here we have the anal triangle. Okay. This is a very important slide. So the pelvic floor is formed by the pelvic diaphragm and the urogenital diaphragm. So your pelvic diaphragm consists of the levator ani, these three muscles here, and then the coccygeus. The levator ani consists of the puborectalis, the pubococcygeus, and the iliococcygeus. So what they did last year was, and hopefully you guys have the same model there, they have a model that shows the muscles of the pelvic floor because obviously you found out in dissection you cannot differentiate between these three muscles in the donor. So if they tag these, they'll use a model. So if you can find a model showing this in the model room, I would definitely suggest looking at that. Because one of the questions last year was just as simple as, they had a sticker on one of these and then they ask you which one it was. So make sure you know those. And then the coccygeus is easily identifiable because it's going to be fused to the sacrospinous ligament. So the same attachments as the sacrospinous ligament, the ischial spine and the sacrum. So if you associate those two together, you won't forget where the coccygeus is located. And then important muscle here, the puborectalis. If this muscle is weak, that can contribute to fecal incontinence. All right. So something they could ask you is what contributes to the formation of the perineal body. So the perineal body is formed by the bulbospongiosis and the superficial transverse perineal muscle. So these two here. And then the sphincter urethrae and deep transverse perineal muscle, the external anal sphincter, and the levator ani fibers. So if I were to write a multiple choice question, asking, what contributes to the perineal body, I would probably throw this muscle right here and there as an answer choice, and then, that would be incorrect. So ischiocavernosus, that would be wrong. So make sure, you know what's forming the perineal body. That's one way they could kind of trick you. Okay, this slide is just like insanely important. You're for sure going to get probably multiple questions from this right here. Okay, so I know the first time that I learned this, I was totally lost. So you have to think about, okay, if I'm standing in front of the donor and I'm looking at their groin or like genital area, we're gonna start from the outside and then go in. So the superficial perineal fascia, this is outside of the body, and then we're moving deeper into the body. So we're dissecting deeper going this way. Um, yeah, so don't let that confuse you. I think what can be confusing is this is referred to as superior fascia of the UG diaphragm, but this is actually the deepest layer. So hopefully that makes sense because the inferior fascia is going to be below the superior fascia. And then also you want to realize that these two spaces, they have very different contents. And you're probably going to get some sort of written question about, what are the contents of these spaces. So in some fancy way, they're going to say, the patient has blah, blah sort of injury affecting this space, which structure is most likely damaged. And something I want to point out is that you need to realize that the greater vestibular glands, so these are female glands, they're located in the superficial perineal space. And then in the deep perineal space, we have the bulbourethral glands. So these are male only. All right, I have a bunch more slides on this. I'm going to just keep going. And we'll get to this more in the male part. Okay, so starting from the outside of the body, so this is the most superficial or most towards the outside, is the superficial perineal fascia. And this is also known as Colles fascia. So remember up in the abdomen, you talked about Scarpa's fascia. Remember scarp, camp out, scarp in. So Scarpa's fascia is going to continue down into the pelvis, and it's going to surround the penis and the scrotum and fuse back here at the perineal membrane. So all of this is Colles fascia, which is a continuation of Scarpa's fascia. Make sure you know that. Okay, next. So we're moving a little deeper. So we're dissecting a little deeper. So Darto's fascia, that I believe is deeper, and we're going to get there. I have a slide later on when we go over male repro, a picture that'll show it. Okay, so next is the superficial perineal space, and just for comparison here, okay, so make sure you can put a picture of the male and female anatomy side by side and figure out what is equivalent between the male and female. So in the superficial perineal space, we have the bulbospongiosis, the ischiocavernosus, and the superficial transverse perineal muscle. Okay, so notice that this, design is very similar between the male and female. So ischiocavernosus, bulbospongiosis, superficial transverse perineal, ischiocavernosus, bulbospongiosis, and then superficial transverse perineal. And then over here, again, super important are these greater vestibular glands. So you want to make sure you remember that the female glands are in the superficial space. The male glands, the bulbourethral glands, those are in the deep perineal space. And then also the erectile tissue is located in the superficial space. So the crura and the bulb of both the clitoris and the penis are located in this space. Oh, and then don't forget, your erectile tissue is anchored to this structure right here. So this is the perineal membrane, also known as the inferior fascia of the UG diaphragm. All right. Next, so going a little deeper, is the deep perineal space. So within this space, we have the bulbourethral glands, and this is male only, and also the external urethral sphincter and the deep transverse perineal muscle. So 3 contents in the deep perineal space. Yeah, let me go back one slide. Okay. So the erectile tissue is located beneath these muscles. So if you compare this picture to this picture, this erectile tissue right here, it's sitting underneath the bulbospongiosis, and this erectile tissue right here is sitting underneath the ischio cavernosus. And when you are dissecting, a lot of times, like, these muscles are very, like, almost paper thin in most of the donors. So as soon as you start ripping off muscle fibers, like, you can almost pick it off, you're getting into erectile tissue. Does that make sense? Awesome. Okay. And then superior fascia. Haley, exactly. That's exactly correct. So superior fascia of the UG diaphragm, I didn't give a slide just for this. Not that important. I mean, obviously it's important, but we didn't get any questions specifically about the superior fascia. More important is this inferior fascia and knowing that the erectile tissue is anchored to the perineal membrane. And then, definitely know the superficial perineal fascia is Colles fascia. So does that make sense, the order of this, that this is most outside of the body, and then going up, you're getting deeper? Or if you start inside the body and move outwards, this is more on the outside of the body. Hopefully that makes sense. All right. Let's do the pelvic neurovasculature. So I heard that people liked this video and this mnemonic after the first session I did over this. So I highly, highly, highly recommend watching this YouTube video that explains this mnemonic. But I'll walk you guys through it real quick, and if it's still confusing, go watch this video because I think that, I think this is one of the best anatomy mnemonics out there, in my opinion. Okay, so your sacral plexus, this is every bit as important as knowing the brachial plexus. So you really want to know every detail of the sacral plexus, and this mnemonic is going to give it to you. Okay, so sacral plexus is formed by ventral rami of L4 to S4. So L4 to S1. Well, first of all, let me go over how you draw this out. Okay, so on your paper, you're going to want to write out the numbers. So you want to go 4, 5, 1, and then come down a bit and write 5, 1, 2, and then write 1, 2, 3, 2, 3, 4, 3, 4, 5. Okay, and you're going to draw boxes. So you'll have a box like this, and so on. So what this is telling you is that nerve roots 4, 5, and 1, or L4 to S1, are contributing to the formation of the superior gluteal nerve. Nerve roots L5 to S2 are forming the inferior gluteal nerve, as well as nerve to obturator internus, and innervating the superior gemellus. Okay, so this is how you read it. And then the reason you draw a line this way is because L4 to S3 is forming the sciatic nerve. Okay, and then underneath of it, you're going to write SIPS, and that gives you the names of the nerves. So S for superior gluteal, I for inferior gluteal, and so on. Do you know P has 3 different nerves associated? Um, okay, so posterior cutaneous nerve of the thigh and posterior femoral cutaneous, that's referring to the same thing. Okay, nerve of the piriformis. Are you referring to this one? I haven't heard that before. I've only heard it this way. And this is what she had in class. Like, this is directly off her slide. So I would go with that, in my personal opinion. Yeah. Okay. So the sciatic nerve emerges below what muscle? Right, the piriformis. Okay. So I threw this slide in here just to make sure that you know what that mnemonic is referring to. So here, right here is your sacral plexus, L4 to S4. And then the reason I put a red box around this lumbosacral trunk is because they tagged this last year, and most of us didn't have a clue what it was, just because they spend a lot of time talking about these 3 and their relationship to the arteries. So make sure that you can identify the lumbosacral trunk in your donor. And I'm pretty sure it's on the lab list as well. Okay, and then also make sure you can identify, of course, the sciatic nerve. So you can see the sciatic nerve here emerging beneath the piriformis muscle. All right, so pudendal nerve is very important. The pudendal has 4 different branches. The most important one, and the one you're most likely to be asked about, is the inferior rectal nerve. So branching off the pudendal is the inferior rectal, supplying the external motor innervation to the external anal sphincter, and then sensory innervation to the skin around the anus. So when you're dissecting in the ischioanal fossa, this inferior rectal nerve is the one that you're most likely to see. So if they tag a nerve, they show you the ischioanal fossa, and they tag a nerve in there, it's probably a safe bet to go with inferior rectal nerve. All right. Okay, so this is my favorite video explaining the autonomics of the pelvis. I highly recommend watching this. It's only, I don't know, 6, 7, 8 minutes, not very long at all. And I think once you watch it, this should be extremely clear. Okay, but I'm going to walk through it. So these plexuses around each of the organs or different tissues in the pelvis, they are formed by mixed autonomic fibers. So mixed autonomic fibers, that means that you're getting contributions from both parasympathetic and sympathetic fibers. So those fibers are coming here together in the inferior hypogastric plexus and forming what we call mixed autonomic fibers. So make sure you're not confused by her slides. She had a typo that said inferior epigastric plexus. It's hypogastric. All right, so forming the mixed autonomic fibers are fibers from your pelvic splanchnics. So S2 to S4 gives you parasympathetic fibers to the inferior hypogastric plexus. And then your sympathetic fibers, and this is bilateral, make sure you realize that, from each side. And then sympathetic fibers are coming from right and left hypogastric nerves, and they are branches from the superior hypogastric plexus, which is formed by thoracic and lumbar splanchnic nerves. So the only thing that he didn't discuss in this video is don't confuse pelvic splanchnics with sacral splanchnics. So sacral splanchnics, and if you want to draw it in here, you can like draw it in up here somewhere if you want. So sacral splanchnics are connecting your sympathetic trunk to the superior hypogastric plexus. So you do get, kind of a small contribution from sacral splanchnics that come down here. And then also, don't let it confuse you. What is the somatic motor nerve coming from S2 to S4? So from S2 to S4, those are the nerve root levels for what somatic motor nerve? Right, pudendal nerve, correct. So I would recommend maybe drawing that into this picture too. And this is a screenshot of like the end product of this YouTube video. So this is what he's going to walk through and explain. Okay, and then this is very, very important. This comes back up several times throughout the year. So point and shoot. Point is referring to parasympathetics, and then shoot is referring to sympathetics. So in order to point, you need vasodilation, and this is going to aid in an erection. And then shoot requires vasoconstriction, and this is aiding in ejaculation. And then also you want to know that parasympathetics, they help with bladder contraction in order for you to urinate, and then also stimulating defecation. So, when you're in the parasympathetic world, like you're relaxed and chilling and, defecating, urinating, you're not going to want to do this when you're under a sympathetic response. So if you're running away from a bear, hopefully you're not going to take time to defecate. And then shoot, the sympathetics, is also responsible for contracting the internal urethral and anal sphincters. So, again, if you're running from a bear, your sympathetic response is going to contract both of these sphincters, basically to... I don't know about that. Yeah, I don't know about that. I would guess no, because, the erection is part of the parasympathetic response. So if sympathetics are engaged, vasoconstriction is going on, so you're not going to get an erection because there's no blood flow to the penis, or there's less blood flow to the penis because you're under vasoconstriction. Yeah. All right, so is everyone good with this picture, or do you want me to go through it again? Yeah, right. Okay. Uh, yeah, if anyone wants me to run through this again, just let me know. Otherwise, I'm going to keep going. Okay, so super important are the branches of the internal iliac. This is probably going to be like multiple tags on your lab practical. So let's break it down. We'll start with the posterior trunk. So your posterior trunk is giving rise to 3 branches. And if you think about the names are going to tell you where they're going. So iliolumbar is going to travel back up to the lumbar region. Lateral sacral is going to come out laterally towards the sacrum. And then the superior gluteal artery is going to travel through the or between these 2 nerves right here to go towards the gluteal region. So superior gluteal artery is traveling between which 2 nerves? So right here, right, so between your lumbosacral trunk and S1. That is correct. Okay. So off the anterior trunk, we have quite a few more. So we'll start up here. This is the umbilical artery, which is going to become what structure out here? So medial umbilical ligament. So out here it's becoming the medial, because it's obliterating and becoming the medial umbilical ligament. And then next, the obturator artery, passing through the obturator foramen with the obturator nerve. And typically off of the umbilical artery, but not always, is the superior vesical artery. So this is going to supply the top part or superior portion of the bladder. And then we have an inferior vesical artery, which is found predominantly in the male. And she kind of explained this in class, but this is kind of one of those gray areas of anatomy, I think. Just because you're female doesn't necessarily mean you won't have an inferior vesical artery, because you still need perfusion through the lower part of your bladder. But this is typically associated with a male because you have arteries branching off of the superior vesicle, supplying like the ductus deferens and the seminal vesicles and some of the male anatomy. All right, next we have inferior gluteal. So passing between S2 and S3 to reach the gluteal region. And I just want to say, so inferior gluteal and superior gluteal are 2 arteries down here that are highly likely to be tagged, just because they can show you that relationship. They can show you the 2 nerves that they're passing between, and then it's like there's no argument at that point what artery it is, because you can see that, or they'll show you that relationship. All right, middle rectal. So this one right here, also off the anterior trunk, and then the internal pudendal artery, giving rise to the inferior rectal. And then you also have a uterine artery, which is not shown here because this, what's a good way of distinguishing middle rectal and inferior? Look at where it's going. If it's going to the rectum, it's middle rectal. If it's going to the bladder, it's inferior vesical. But to be honest with you, I don't recall them tagging inferior vesical last year. Like, I think that's one of the ones that's like less commonly, or not as easy to identify, let's put it that way. But yeah, when going to the rectum, definitely middle rectal. Okay, so also you're going to have a uterine artery, which gives off a vaginal branch. And this is not shown here because they're showing an inferior vesical artery, so this is like the male schematic. But just know, if you see an artery going to the uterus, that's going to be your uterine artery. And then also realize that the vaginal artery in females is equivalent to the inferior vesical artery in males. Okay. And then I threw this in here just to kind of like help make some connections. So if you remember from last block, the superior rectal artery is coming from the IMA, the middle rectal artery that we just talked about is coming from internal iliac, and then an inferior rectal artery is coming from internal pudendal. So, now you kind of have like the complete picture there. Okay. So I listened to these lectures today, and she said these right here, so everything below ovaries and testes, these are things you need to know for boards, and this right here is what you must know for MGA. And she like literally went over this after every repro lecture. So if she doesn't ask a question about it, like I would be kind of annoyed. So the most important one she said to know is the fact that the ovaries and testes are going to drain into the para-aortic lymph nodes. Hey, can somebody who doesn't have their mic muted, can everyone check and make sure that your mic is muted? Awesome, thank you. Okay, so anyways, this is kind of unique because they're skipping, from the genital area all the way up to the lumbar region. So make sure that you, at minimum right now, know this one right here. Okay, and then again, lymph from the testes and ovaries is going to drain directly to the lumbar or the para-aortic nodes. And I have those circled right here. So it's going here and draining all the way up here. All right, so let's do the female anatomy. She did come out and say that you will get a question about this, and I can say from experience that they tagged this relationship on the practical last year. So definitely know that the water under the bridge is referring to the fact that the ureter travels underneath the uterine artery. Does anyone know why this is so important clinically? And this might help you remember it. Right? So what can happen during a hysterectomy? Like, give me more. But why is this relationship important? Right, you can nick the ureter. Yeah. Which is obviously going to lead to, all sorts of like kidney-related issues. Right, when you're ligating the uterine artery. Exactly. You can damage the ureter. Okay. Now let's do the bladder. So the muscle of your bladder is known as the detrusor muscle. And then you're also going to have an internal urethral sphincter and an external urethral sphincter. So what space, referring to the UG diaphragm, is the external urethral sphincter found in? Which space? Yes, the deep space. All right, and then also, so you want to know this right here. When your sympathetics are in control, the detrusor muscle is going to relax, which allows for filling of the bladder, and your internal urethral sphincter is going to contract. Yes. So this is going, I, I, bel I believe so, but I could be wrong. I'll double check on that for you here towards the end. Okay. If your parasympathetics are in control, then the detrusor muscle is going to contract and the internal urethral sphincter is going to relax. So, if you think about it, you don't want to pee yourself again when you're running from a bear. So you want to make sure that the sphincter contracts and then the detrusor muscle relaxes to allow the bladder to fill without you needing to urinate. Okay. And then also, this is out of first aid, talking about the relationship of the uterine artery and the ureter. It's a very important relationship. Okay, and then I made this slide. I don't know if this is helpful at all, but it's sort of just talking about the same thing. It's showing you the pathway that controls the contraction or relaxation of the detrusor muscle and the internal urethral sphincter. Okay, so what is the effect of the sympathetics on the internal urethral sphincter during ejaculation? So why do you want that to contract during? Prevents mixing of what? Right. So you don't want to mix urine with semen. All right. All right, here we have the female urethra and then the male urethra. So 4 important parts of the male urethra are the pre-prostatic part, the prostatic part, the membranous part, and then the spongy part. And yeah, now that I'm looking at this, I think you may be right. I don't think they have an internal urethral sphincter, which makes sense because you're not worried about the mixing of anything as a female when you urinate. So, yeah, you're right. So females just have an external urethral sphincter. But I would definitely, most important thing to know is the 4 parts of the male urethra. So make sure that you know these 4 parts because I'm pretty sure that they have a model of this somewhere that they could use to tag each of the parts. All right, so some female external. Yeah, so many parts. Okay, so female external genitalia. You really just got to chalk this up to memorization. So the mons pubis, that's this fatty eminence that lies over the pubic symphysis. Parts per million. Oh, I gotcha. Yeah. Then the labia majora are these larger folds out here. The labia minora are the folds that are located more on the inside. And then you have the vestibule, so out here, showing the vestibule. and then the clitoris and vestibular glands, and then the posterior commissure would be right back here. All right. So make sure, again, make sure that you know all of these muscles. So ischiocavernosus, bulbospongiosus, and then superficial transverse perineum muscle. Okay, and then over here, remember the greater vestibular glands. And then the glands in the male are called what? Right, bulbourethral or Cowper's glands. And those are shown right here. Okay, so yeah, spend some time comparing these pictures. And, again, yeah, realize that this musculature is located on top of the erectile tissue. And you can kind of see in this picture where like the erectile tissue is like peeking out. So they're showing you that it's located underneath of the muscle. Okay, and then again, the deep space, remember bulbourethral glands only found in the male, and you also have the deep transverse perineal muscle and the external urethral sphincter. Okay. I believe in lecture she said that you would have a question asking you about the homologs of the external genitalia. And I think in our practical last year, they did something where like they would tag a structure on the female and then they would ask you for the male homolog. So that's kind of a way that they can make a second order question in the practical. So make sure you know this chart. Okay. So we'll start with this picture up here. How would you describe the uterus? I put one word, but there's actually two words that you could use. And by how would you, yes, that's correct. Anteverted and anteflexed. So that's referring to its positioning. And based on that, you can tell that this is the anterior fornix, and then this is the posterior fornix, since the uterus is anteverted and anteflexed. Okay, so a lot of important stuff on this slide. So first, the broad ligament. So the broad ligament is made up of the mesosalpinx, the mesovarium, and then the mesometrium. And then also, she pointed out to make sure that you don't confuse the ovarian ligament with the suspensory ligament of the ovary. So the ovarian ligament is attaching the ovary to the uterus, and then the suspensory ligament has located within it this vascular bundle, so connecting it to the wall. And then, up here you have the fundus of the uterus, and then endometrium. So if you've heard of endometriosis, it's referring to the endometrium of the uterus. And then myometrium, this thick layer. It's probably more of a histo question here. And then also your cervix. Within your cervix, you have an internal os and an external os. Okay, the reason I added this slide is that I noticed that first aid refers to the suspensory ligament of the ovary as the infundibulopelvic ligament. And I've also seen this in practice questions. So if this is something that come up on boards, I don't want you to be like, oh, I've never heard that before, because it's just another name for the suspensory ligament. Okay, so the fallopian tubes, all you really need to know here are a few parts of the tube. So the fimbriae, the infundibulum, the ampulla, and the isthmus. What is occurring in the ampulla of the uterine tube? Kind of a throwback from the last exam. Well, you don't want implantation to occur there. Yeah, fertilization. Where would implantation occur? Correct. All right. So more ligaments here. We have the ligament of the ovary connecting, again, the ovary to the uterus. The round ligament running from the uterus to the labia majora. The uterosacral ligament from the cervix to the sacrum, right here. And then the transverse cardinal ligament from the cervix to the pelvic wall. So, did you guys talk about uterine prolapse in class? I forgot. Yeah, so if the uterus was to prolapse, which ligaments or what ligament do you think would most likely be compromised? So think about what's holding the uterus up. What is anchoring the uterus to the body wall? Right, the cardinal ligament, and then also the uterosacral. My guess would be that the cardinal ligament is more important, but I don't know that for sure. I mean, they both definitely contribute. I'm not sure if one more commonly contributes to prolapse or whatever. We don't have repro to the spring, so I'm sure that's something they cover then. Okay, so male repro. All right, so the male external genitalia. So everything is labeled here for you. The most important thing I wanted to talk about is how do you distinguish the dorsal side of the penis from the ventral side? Yes, that is correct. The erection is an anatomic position. Um, well, I guess be more descriptive. So, which one of these is anatomic position? Right, the left. Okay. So what would I call this side of the penis? Dorsal or ventral? Ventral, yeah. Ventral, dorsal. Okay, that can be confusing, but you have to think of the penis in an anatomical position. All right. Okay, so here is that Buck's fascia. So Buck's fascia is this deep fascia encircling the erectile tissue within the penis. So whoever asked me about that, here's a good picture of Buck's fascia. Oh, and okay, so most important thing here, I think they did this in the practical. So I don't know if anybody has made a cross section through the penis yet, but on the practical they did this, and then they tagged one of these erectile tissues. So make sure you know that these are the corpora cavernosa, and then this is the corpus spongiosum. And then passing through the corpus spongiosum is the spongy urethra. Is Buck's fascia also dartos? Let me go back to this slide here. Let me look that up when we get to the end, just so I don't tell you incorrectly. As soon as we're done with this, I will look that up to make sure before I give you an answer to that. Okay, so again, with the male urethra, but here I wanted to point out the difference between the external and the internal urethral sphincter. Okay, so you want to know that the external urethral sphincter is located in the membranous part of the urethra, and again, in the deep space of the UG diaphragm, and then the pre-prostatic urethra, that is going to contain the internal urethral sphincter. Okay, so most important point from that slide. And then here, this is just talking about, if you have an injury to Buck's fascia, so that deep fascia, urine is going to escape into the perineal space. And then if you have an injury in the anterior urethra, then you're going to have blood accumulating in the scrotum, versus a posterior urethral injury, you're more likely to have urine leaking into the rectopubic space. All right, and then this last year was a test question. So 4 lobes of the prostate, and then the posterior lobe, this is the most common location for prostate cancer. So I would definitely, at minimum, commit this to memory. All right. This slide here is just showing you the pathway of sperm. So you want to know that sperm is going to start in the seminiferous tubules and then travel through the straight tubules, the reedy testes, the efferent ductules, and then out to the epididymis, and then through the vas or ductus deferens. So you're going to hear both of those used interchangeably, vas deferens. Ductus deferens is referring to the same thing. And then it's going to travel, through the different parts of the urethra to, of course, exit the penis. Okay, and I just threw this in here from first aid. So the mnemonic they use is 7-Up. This isn't, I guess this is fine for boards, but I think either in histo or anatomy, this was a multiple choice question, and they had the straight tubules and the reedy testes and efferent ductules. They had that in the question. So make sure, if you do use that mnemonic, make sure you don't forget about this here. Okay, again, water under the bridge. I put this in here again because we talked about water under the bridge in reference to the female, and I think this is the most commonly, this is the way you're most likely to be asked about it, is in context of the female anatomy, because the ureter is often injured during hysterectomy. But this relationship also exists in the male, where the ureter passes underneath the ductus deferens. But they're going to tag it in the female, most likely. Okay, accessory glands. So we got a question on the lecture exam about this last year. It was basically asking, something about she's going to like pick one of these and ask what it contributes to the formation of semen. So, you want to know that the prostate gland contributes the acidic prostatic fluid, the bulbourethral glands, they contribute, an alkaline mucus, and then the seminal vesicles secrete a fructose-rich seminal fluid. So make sure you know what each of these are secreting. Okay, and then again in the deep space. Oh, there it is. All right. So they could, I don't know, they might tag this in the donor or they might tag this on the body. Make sure you know the difference between ductus deferens and seminal vesicle. That was my main point in including this slide. All right, and here, so what you need to take away from this slide is that each of Dartus, oh yeah, here's Dartus. I'm pretty sure that Bucks and Dartos are the same, just based on this slide. Okay, so each of the abdominal wall layers are going to contribute to a different layer in the scrotum. So I would definitely take a look at this and try to commit this to memory. And I think if you think about it, like, it's not too bad. Dartos fascia is going to be more superficial than the internal spermatic fascia, so it's coming from closer to the skin. Okay, all right, thank you. Yeah, thank you for looking that up. Okay. Yeah, so if you want to make a note in here that Buck's fascia is the external spermatic fascia. Yeah, thank you guys so much for looking into that. All right, and then down here, just a little bit of development. So if the processus vaginalis does not close, you get what's known as a patent processus vaginalis. And then you can have a hematocele, which is accumulation of blood in the tunica vaginalis, or a hydrocele, which is an accumulation of fluid. And also you have the potential for an indirect inguinal hernia. I don't remember being tested on this last year, but just in case. Okay, so they did tag this. So they did exactly what was shown in this picture here and tagged the tunica albuginea. So your tunica albuginea is going to be deeper to the tunica vaginalis. All right, so that's really the most important thing here. All right, and then also the contents of the spermatic cord. So here's a mnemonic. If you like it, pills don't contribute to a good sex life. And this is going to give you the contents of the spermatic cord. And last year, I want to say they tagged the piniform plexus. All right, are you ready for some practice questions? Yes. Okay, so I heard a lot of people struggled with questions that would test relationships on the lecture exam. So I decided to just go straight to grades this time with the practice questions. So these, I mean, in my opinion, some of these are more difficult than what you would see on the test, but I think it's better maybe to go more difficult than too easy. All right, so 25-year-old male is admitted to the hospital with testicular pain. Physical exam reveals a swollen and inflamed right testes. CT scan reveals abnormal accumulation of fluid in the cavity of the tunica vaginalis. Which of the following conditions would most accurately describe the signs observed in the patient? Okay, so before you just assume that you don't know this, think about what these words mean. So varico is referring to veins, recto is referring to the rectum, hydro is referring to fluid. Right, so the correct answer is hydrocele. And I know somebody's going to ask me this. Don't worry about this word. I had no idea what it was until I looked it up. But it's some sort of like congenital problem that can occur in males when they're born. Okay, but you're not going to see this on the MGA exam. Okay, so correct answer is D. Next, a 54-year-old male is admitted to the hospital with severe back pain. Radiographs reveal carcinoma of the left kidney, blocking drainage of the testicular vein. Which of the following conditions will be most likely associated with these signs? Yeah, when the urethra is on the ventral side of the penis. Yeah, that word, forgot what it was already. Hypospadias. Yes, J-Bay is correct about that. Right, you guys are right. So the correct answer is A. All right, next, a 16-year-old female is brought to the emergency department with severe abdominal pain and fever. Labs are remarkable for an elevated white blood cell count, positive for pregnancy. Colpocentesis is performed to ascertain the presence of blood in the pelvis from a ruptured ectopic pregnancy. Through which of the following structures does the needle need to be inserted? Yes. You guys are rocking these. So the correct answer is B, through the posterior fornix into the recto-uterine pouch. So that was, remember, the one with the star by it. Okay, 22-year-old male complained to the urologist of pain that he experiences from bladder fullness after drinking large quantities of fluid. What is the location of the neural cell bodies responsible for pain sensation? Haley, I'm honestly not sure. We have never gone into that much detail. We don't have reproductive spring. I'm guessing it's usually the posterior fornix just because it's easier to access that way. That would make the most sense to me. Um, I can't imagine like why they would go through the anterior because it would be much easier to reach, behind the uterus. All right, you guys are doing great. Correct answer is A. Okay, next, a 55-year-old woman complains of fecal incontinence. The most likely contributing factor to such a problem is atrophy, paralysis, or dysfunction of which of the following structures? Okay, so the most correct answer is not listed here, And that's because if they listed the most correct answer, they give it away. So the correct answer is also a contributing factor. Yeah. And you guys doing great. You got it. So the answer is A. And it even says in the explanation here, the pubococcygeus, and especially its most medial portion, the puborectalis, is of most importance in fecal continence. So according to Gray's, both of these are playing a contributing role. Alrighty. 45-year-old obese woman admitted to the hospital because of pain in the leg. Physical exam led to a diagnosis of myalgia paresthetica. In her condition, excessive adipose tissue bulging over the inguinal ligament exerted traction on it, compressing a nerve that passed through or beneath the ligament, just medial to the ASIS. This is more of a leg question, but this is like a very likely question that you would see on your lecture exam. Yeah, and it's the lateral femoral cutaneous. However, they're not going to use myalgia paresthetica because that's considered a buzzword. So like a buzzword is like you hear one word in the question stem and you can like immediately get the answer. They've told us that they're trying to eliminate all of those from the stems. So if that's the case, so if we were to take this out, like how could the stem describe her pain that would lead you to get this answer? Does that make sense what I'm asking? Like if they didn't tell you myalgia paresthetica, like what signs or symptoms are you looking for? Right, but like what could you add to the question stem? Like how would they describe the pain or the location? Yes, that's what I was looking for. Numbness to the lateral thigh. So that is more likely what you would see in the question stem, like a decom, if that makes sense. So don't expect buzzwords like myalgia paresthetica or hipster syndrome. Okay. On digital exam of the vagina, the portion of the uterus that one anticipates palpating with the examining finger is the cervix and its external os. Which of the following is the most common position of the uterus? Yes, awesome. You guys got it. So anterooted and antiflex. 42-year-old woman is admitted to the emergency department because of pelvic discomfort. During physical exam, the gynecologist discovers that the patient has suffered complete uterine prolapse. Which of the following ligaments supplies direct support to the uterus? Yep, you guys got it. That cardinal ligament. I have never heard it called Mackenrod's ligament, FYI. Probably cardinal ligament or transverse cervical ligament is what you're going to hear from DCOM. All right, 34-year-old woman is admitted to the hospital due to severe lower abdominal pain. Radiographic exam reveals tumors of both of her ovaries. Biopsy is ordered, confirms diagnosis of cancer. Which of the following lymph nodes are the first to receive lymph from the diseased ovaries? Yes, C. So I would put a star by this one because she pretty much came out and said that you're going to get a question about this. And I think this is like a totally reasonable, stem that you might see on your exam. Okay. 29-year-old pregnant woman admitted to the hospital during vaginal delivery. The OB performs a median episiotomy in which the area of the perineal body is cut deeply 2 weeks after delivery. She complains that she has fecal incontinence since the delivery. Which of the following structures is most likely damaged during the episiotomy? And yeah, so think about, no, it's not too obvious. Yeah, I mean, you might like write this. I think the tendency might be that, oh, I'm going to write this question off because I don't know anything about episiotomies, but like just think about her. What symptoms does she have? So yeah, B is the correct answer. External anal sphincter, because she complained of incontinence. Okay. 34-year-old woman admitted to the hospital complaining of urinary incontinence. MRI reveals that one of the skeletal muscles of the pelvis has a significant tear. Which muscle is most significant in terms of maintaining continence? Yeah, good job, Haley. So kind of the same question again. Pubococcygeus. So we have a 34-year-old woman whose automobile collided with a lamppost, and her urinary bladder gives evidence of paralysis. A CT scan reveals multiple fractures of her pelvis with a significant hematoma, either of which could have interrupted or injured the nerve supply of that organ. Which of the following nerves was most likely traumatized? A little bit tougher question here. Yeah, so yeah, this one's tougher. So think about, only one of these are directly supplying the bladder. So the answer to this one is B, because it receives parasympathetic innervation from the pelvic splanchnics. So go back and look at that slide where we talked about the innervation of the bladder. Okay, so another woman in her 30s, hospitalized because of an enlarged, painful abdomen. The ultrasound is performed, and she has ascites, so fluid accumulation, in the peritoneal cavity. A needle is placed through the posterior vaginal fornix to drain the fluid. What space did it enter? Yeah, I think you guys got that one all down. And like I added this one too because I just wanted to show you like different ways that they could ask this question. But she said you're going to get a question about it. So you guys are going to get this one for sure. All right. 60-year-old man complains of pain upon urination. CT and biopsy provide evidence of an enlarged cancerous prostate gland. Subsequently, he undergoes a radical prostatectomy. Postoperatively, he suffers from urinary incontinence because of paralysis of the external urethral sphincter. Which of the following nerves were injured? Okay. So yeah, so the answer, so this is referring, see, I think Personally, the same sort of thing gets me on exams. So your mind kind of jumps to bladder, but it's talking about the external urethral sphincter here. So the answer to this one is going to be the pudendal nerve, responsible for innervation of the external urethral sphincter. And like honestly, guys, I think a lot of these are more difficult than what you're going to see on the exam. But still good practice, just in case. Okay, a 65-year-old male with a history of heavy smoking and hypercholesterolemia is diagnosed with severe atherosclerosis affecting most of the arteries. During the taking of the patient's history, he complains of impotence. Occlusion of which of the following arteries would most likely be the cause of this condition? If you just think about the relative location of these, you could probably get it right. Yeah, so both of you are correct. The internal pudendal artery gives rise to the dorsal artery and deep artery of the penis. So it's responsible for the blood supply to the erectile tissue. And so if he has impotence, he's not going to get an erection. So you have a compromise of this internal pudendal artery. All right, next, a 42-year-old woman visits the outpatient clinic due to painful urination. Dipstick reveals leukocytosis, which confirms the diagnosis of urinary tract infection. Which of the following is the best anatomic explanation for the fact that women are more susceptible to urinary tract infections? Yeah, so this question is not bad at all. The urethra is much shorter in females. Oh, and also I wanted to say, I don't know if you guys ever read a question stem and you're like, oh my gosh, I don't know what some of these words even mean. So like this is a good example of like, even if you didn't know what leukocytosis was, you could still very easily answer this question. All right, moving on. A 47-year-old woman with a family history of breast cancer mutations in the BRCA1 and 2 genes has made a decision to have an elective hysterectomy as a prophylactic treatment. During ligation of the uterine artery, which of the following adjacent structures must you be careful not to injure? Yes, awesome. So he has to make sure he doesn't injure the ureter. So remember the water under the bridge. Okay, next. A 45-year-old woman is admitted to the hospital with lower abdominal and pelvic discomfort. Combined laparoscopic and MRI exams reveal tears of the ligaments supporting the uterus with moderate uterine prolapse. Which of the following ligaments provides direct support to the uterus and thereby resists prolapse? Yeah, so the answer that you're looking for isn't here, but what is the second best answer? Yeah. So uteral, sacral, and cardinal ligaments are preventing uterine prolapse. A 68-year-old male underwent a radical prostatectomy 6 months postoperatively. The patient complains of being incapable of penile erection without the use of sildenafil. Which of the following nerves was most probably damaged during the operation? Yeah, so think about your point and shoot. Yeah, and those of you that answered, C, yeah, point and shoot. So C is the right answer because penile erection is a parasympathetic response. So remember, point, you're getting vasodilation, which facilitates the erection. So pelvic splanchnic nerves would be the correct answer. Okay. A 15-year-old is admitted to the ER 2 days. Yeah, I mean, you have a good point there. It's not the best mnemonic because erection is an autonomic response. It's because the pudendal nerve is a somatic motor nerve, and it's coming from nerve roots S2 to S4. So yeah, that's a really good point. I've been betrayed, but now you know better. So okay, uh, we haven't done this one yet, right? Okay. So a 15-year-old is admitted to the ER 2 days after crashing his bike. MR reveals severe edema of the boy's scrotum and abdomen and extravasated urine. Which of the following structures is most likely ruptured? That's awesome. Yeah, I love that. You need to tell Dr. Hermy that. That's great. Correct. So the answer to this one is A, the spongy urethra. Okay. A 19-year-old woman is admitted to the hospital with low blood pressure and intense pelvic pain. Physical exam reveals heavy blood loss during menstruation. Speculum exam reveals irritation of the cervix and uterus. Which of the following nerves conveys sensory fibers from the cervix of the uterus? So I think sensory. Do we have any other takers? Okay, so this question, and I didn't really go over it, but hopefully we can learn from this question. So, pain from the cervix is transmitted via pelvic splanchnics because it's below the pelvic pain line. So, if you have pain above the pelvic pain line, it's carried via nerves that are primarily sympathetic in function. She kind of like glossed over that in class, I feel like. Where's the line? Yeah, I don't remember the exact location of the line, to be honest with you. I think she had a slide on it somewhere. Let's go on to the next question. I'll look that up while you guys are reading this question. Yeah, so go ahead and type in your answer to this question while I look that up. Right, so the correct answer to this one is B. So the left testicular vein drains into the left renal. So left testicular also referring to left gonadal. And I think this was on your last exam, right? Okay, so what I can find just from looking real quick about the pelvic pain line, it says any organ in the pelvis is said to be above the pelvic pain line if it is in contact with the peritoneum. So if it's not in contact with the peritoneum, then it's considered below the pelvic pain line. Okay, so a 34-year-old woman is admitted to the hospital with perineal pain. Lab blood tests reveal marked leukocytosis. Physical exam reveals abscesses in the anterior recess of the ischial anal fossa. A surgical procedure is performed to debride and drain the abscesses. Which of the following nerves will most likely need to be anesthetized to specifically numb the surgical area? So think about the location. The ischioanal fossa. Right, so the correct answer here is the perineal nerve. Would need to be anesthetized because it supplies the area that is described. All right, we're almost done, guys. A 37-year-old woman is admitted to the hospital with pelvic pain. Radiographs reveal a benign tumor on the left ovary. An ovaryectomy is performed and the ovarian vessels are ligated. Which of the following structures is most at risk of injury when the ovarian vessels are ligated? Right, great job. So that's the ureter, and this is just a question testing if you know the relationships. All right, I think this is the last one. A 79-year-old man is admitted to the hospital for a scheduled radical prostatectomy. 6 months post-operatively, the patient visits the outpatient clinic complaining of impotence. Where are the nerve cell bodies located responsible for erection? So first of all, think about point and shoot. And then think about what point means. All right, so the answer here would be A. So sacral parasympathetic nucleus. Yeah. All right, if you're wondering about the questions that I skipped in Gray's, it's just because I thought that they were like way too clinical, like stuff that neither of us have learned about, or way too difficult. So I tried to pick out the ones that I thought were like most relevant. Do people purchase Grays if they hate ebooks? Oh, I have no idea. Well, the original Grays, like the Grays Bible, is giant, and that's probably spendy. But I think people are using the Grays Anatomy Review, like for students. Um, that one's, if I had to guess, probably a lot cheaper. So if you do purchase it, make sure you don't purchase like the big Grays. Purchase the student version. You get my drift. So inferior hypogastric plexus, I mean, it's containing mixed fibers, so I don't know if that would be like the best choice. I mean, I guess if there wasn't a better answer choice. All right, guys. Thank you guys for helping me out with the whole Bucks versus Dartos debate. I apologize for not knowing that, but I don't remember them testing on it last year, so probably not a huge deal. All right, thanks, guys. If you guys need anything, if you need any resources, PDF copies of textbooks, feel free to send me an email or Facebook message. I probably have it, or I can find it and get that to you. So even if it's not for anatomy, yeah, as far as I know, I'm still recording. So just give me until like noon tomorrow. Sometimes the processing speed on YouTube is really slow. So yeah, at least giving me to tomorrow to get it uploaded. Um, yeah, if you guys need anything, let me know. All right, make sure you signed in. Let me know if I need to post that link again.